Hello everyone, welcome to all the delegates. I am Dr. Darpan Thakre, Senior Resident in Department of Clinical Immunology and Rheumatology at SGPGI Lucknow. Today I will be describing a case of young male with the title The Boy Who Lived. This 12-year-old boy presented to us with a history of bilateral symmetrical inflammatory polyarthritis of small and large joints of upper limb and lower limb for the past 1.5 years. He was diagnosed as JIERA from outside and was treated with low-dose prednisolone and NSAIDs, on which he had symptomatic relief in his polyarthritis. 6 months prior to presentation to us, he started having proximal muscle weakness such that he had difficulty in getting up from squatting position and difficulty in overhead abduction. This proximal muscle weakness gradually progressed over the period of time such that 1 month prior to presentation to us, the patient was bed bound and had difficulty in turning over the bed. He also had bilateral ulcerative lesions over the knuckle, which were mainly present in the second and third knuckles. He had dyspnea on exertion, which was gradually progressing for the past 2 months. 15 days prior to presentation to us, he started having bilateral periorbital puffiness. On presentation to us, his vitals were stable. He had heliotrophic rash. He had decubitus ulcer of 2 into 2 cm. He had diffuse alopecia, ulcerating gouton papules or the second and third MTP joints. His tender joint count was 20, swollen joint count was 0, single breath count was 14, and muscle power by MMT scale was 52/80. On systemic examination, he had bilateral crepitations till middle zone, and on per abdominal examination, he had hepatomegaly 1 cm below the subcostal margin. Considering the clinical scenario in mind, the diagnosis of dermatomyositis, that is MDF5 dermatomyositis, was certain. On evaluation, he had anemia with hemoglobin of 9.8. His ESR was 98. He had hypergammaglobulinemia with globulin levels of 5.1 gram per dl. His muscle enzymes were raised. His SGOT was 389. SGPT was 124. His LDH was 2023. His total CPK was 162 and his ferritin was 2410. On autoantibody workup, his ANA was 2 plus co-speckled. His MSA was positive for MDF5. His HRCT chest showed mild bilateral pleural effusion, patchy areas of consolidation, and ground glass opacities, mainly in the bilateral lower lobes, and he had reverse halocine in some areas. So the possibility of organizing pneumonia, viral pneumonia, and fungal pneumonia were kept for this patient. The possibility of viral pneumonia and fungal pneumonia was ruled out in this patient, and the patient was diagnosed as MDF5 dermatomyositis with rapidly progressive ILD. He was started on combined immunosuppression, that is high dose glucocorticoids, and received 3 doses of pulse MPS followed by 1 mg per kg prednisolone. Along with, he was started on tacrolimus and IV cyclophosphamide. Patient had improvement in his symptoms on the treatment, but he missed his 3rd dose of cyclophosphamide and he tapered the dose of prednisolone on his own. He presented to us again with 1 week history of fever, bleeding from gums, melena, petechial rash, worsening of the muscle weakness. On evaluation, his hemoglobin was 7, his total leukocyte count was 2700, his platelets were 6000. So the possibility of macrophage activation syndrome was considered in this patient. On evaluation, his serum fibrinogen was 120, his serum triglycerides were 387, his serum ferritin was 1360. Bone marrow examination was deferred in this patient because of the financial constraints. He received 3 doses of pulse MPS again, and his tacrolimus dose was increased. Patient has improvement in his symptoms on the treatment and was discharged with hemoglobin of 8.7, total leukocyte count was 5400 and platelets of 80,000. Here we have described a case of MD5 juvenile dermatomyositis with rapidly progressive ILD complicated with macrophage activation syndrome. The estimated prevalence of anti-MDF5 dermatomyositis is around 7 to 10% in the European cohorts and 25% in the Japanese cohorts among all adult dermatomyositis patients. In children, the prevalence of MD5 dermatomyositis is around 10 to 40% out of all juvenile dermatomyositis cases. The incidence of rapidly progressive ILD is around 19% in the Japanese cohorts of MD5 juvenile dermatomyositis, and in the incidence of rapidly progressive ILD is less than 10% in the Caucasian MD5 juvenile dermatomyositis cohort. Among all dermatomyositis, MD5 dermatomyositis has the highest association with the ILD, with the estimated prevalence of ILD is about 90%. Among all the ILD patterns, the most common pattern is organizing pneumonia with the prevalence of around 50%, followed by NSIP and organizing pneumonia overlap, which is present in 30% of the patients, followed by NSIP ILD pattern, which is present in 20% of patients. Other patterns like UIP and AIP pattern were found in less number of patients. Along with that, the signs of fibrosis were found in 40% of the MD5 dermatomyositis patient, and the non-significant adenopathies was found in 30% of MD5 dermatomyositis patient. Among the prognostic factors, ferritin is the most important prognostic factor in MD5 dermatomyositis, with studies showing that ferritin level of more than 1600 nanogram per ml is associated with the reduced survival in patients with MD5 dermatomyositis. This patient with MD5 dermatomyositis with rapidly progressive ILD should be treated with combined immunosuppression. This Japanese study shows that the 6-month survival of patients receiving combined immunosuppression was 89%, which was significantly higher than the historical cohort of 15 patients who received step-up therapy of high-dose glucocorticoids and additional immunosuppression, which had survival level of 33%. Regarding the macrophage activation syndrome in dermatomyositis, it is considered as a rare complication, with the literature review revealed only 19 adult patients with dermatomyositis associated with macrophage activation syndrome, and most of these patients developed macrophage activation syndrome within the first 3 months of the onset of symptoms. And only one case report of macrophage activation syndrome in MD5 juvenile dermatomyositis has been described in literature till now. So our patient could be the second reported case of macrophage activation syndrome in MD5 juvenile dermatomyositis with rapidly progressive ILD. Thank you.